Well, good morning. It is a humbling introduction, and I am really touched by the generosity of Dr. Marin's words. I'm also thrilled to be here and to be on the faculty with friends and colleagues that I've known for quite a period of time. I'm amused by the introductions. If Dr. Nishimura is a plain old cardiologist, and if Dr. Reardon is a country surgeon from Texas, what do you say about a guy from Chicago? I'm just not sure. So I'll leave that up to your own devices. I am really going to focus on what I think is the most precious part of this conversation. I say precious because it really has great bearing on outcomes. It really has great bearing on patient management, and it really forces us to think beyond the valve and think about the ventricle, and specifically to think about heart failure in these discussions. I do have the privilege of serving as deputy editor for JAMA Cardiology and working very closely with Bob Banau. And I thought this presentation in our journal a year ago was incredibly profound because it tracked the 50-year history of our understanding of aortic stenosis as it evolved from the brain trust of John Ross and Eugene Brunwald. This was the anniversary of that seminal moment when they really conceptualized what this natural history looked like. My colleagues this morning have shared with you that we've done an amazing job in the field to significantly change this curve. We're able to intervene long before you see the onset of symptoms, typically angina, syncope, and heart failure. And now we're able to apply transcatheter technologies even in lowest risk patients and to do so skillfully. But I would really highlight two things you heard this morning. I really agree with Dr. Nishimura that the future of our candidate selection really will be built on a much more mechanized way of considering candidacy. Machine learning or some iteration thereof should be of great benefit to us going forward. And I significantly embrace the concepts that Dr. Reardon shared with you, that we need to keep in mind constantly whom it was that was not included in the trials, and to recognize that our patients will come to us with an assortment of comorbidities and mitigating circumstances that are important. I also want to thank Dr. Moran for recognizing an increasingly important part of my professional profile, which is advocating for health equity. I thought that this publication from the TVT registry was of great importance, and it is important for us to pause this morning and think about these evident or potential disparities in the utilization and outcomes of TAVR. I share everyone's enthusiasm about the breakthrough that this represents, but look at these data very carefully. The ordinal axis gives us a sense of the percent utilization of TAVR as a function of either race, that is black or white, or ethnicity, Hispanic or not. Those numbers are at the threshold of 5% or less, substantially below the representation in the community. And unless we can make an argument that the biology is different, we're dealing with a scenario that gives us reason to pause. There certainly is a survival disadvantage, and so maybe this is a phenomenon of survival, but there still is an unanswered question about what happens when we have to not only look at objective data, but make a decision about a person in front of us. Are we able to navigate those decisions equitably? Let me also share with you the growth that we've seen. You've heard this already from Dr. Reardon, you heard this already from Dr. Sharma. You can see the number of centers that are now performing TAVR going up almost exponentially, with virtually no increase in the representation of those patients undergoing the procedures. There is a question here that needs to be resolved, and I would argue that it's worth our consideration. And now when you look at a heat map of where procedures are being done according to race and ethnicity, you see striking differences as a function of Hispanic ethnicity or not, black race or not. These are things that we should continue to think about going forward. Let me shift the frame now, because when we're talking about critical aortic stenosis or severe aortic stenosis, that is not a condition that is amenable to medical therapy. I should say that yet again. That is not a condition amenable to medical therapy. It requires an intervention. The symptoms may well be heart failure. That means someone has missed an opportunity for diagnosis, but the therapy really requires an intervention. But it's a different calculus when we're looking at secondary or functional mitral insufficiency, because this arguably is a problem less so with the valve and more so with the ventricle. That means then that the data that we embrace from COAP are stunningly important, because it demonstrates that within that group of individuals with functional MR, there is a potential, substantially so, for improvement with an intervention. These are the words that the FDA coined to approve transcatheter therapy for mitral valve repair. And I've bold-faced what's most important. These patients are approved to receive this procedure if they persist with mitral regurgitation of importance despite being treated with optimal medical therapy. And this is in the context of having heart failure. So this is a pause moment. This is the first time this morning that you've really heard emphasis on this context of heart failure as a necessary component of your professional decision-making about mitral valve interventions. Who were those patients in COAP? What kind of heart failure are we identifying? When we look at the tabular data, we see a couple of things that I've highlighted here to really bring emphasis. The first, we see the vast majority had class 2 and 3 heart failure, not class 4, less than 1%. The other thing that's important is you look at those patients with a previous hospitalization for heart failure. That is a significant mark of risk. And look at the thresholds of the natriuretic peptides. For the NT-proBNP at 5,000 or greater, BNP at 1,000 or greater, these do qualify as negative prognostic indicators and give us a sense that this is at least a moderately severe heart failure. But again, caution about class 4, 6% in one arm, 10% in the other arm. Now, most of us have become comfortable making the argument, and Rick referred to this and then left it very quickly for good reason, but most of us have become comfortable that there was some variance between COAP and MITRA-FR as a function of mitral insufficiency. But I think there's another more important consideration. Who is actually enrolled in COAP? You won't find this in the primary publication. You have to go into the supplement, many pages into the supplement. But once you do that, you realize that about 40% of the patients who were felt to be adequate candidates did not enter the randomization phase. I highlighted for you with the purple arrows what the limitations were. 15% ended up with inadequate MR, particularly after being placed on evidence-based medical therapy. 25% were not on sufficient GDMT, and then 5% were on no GDMT. Now again, this is a critically important part of the conversation. As fascinated as we all are with the evolution of the technologies, it is the patient-first context that needs to be considered. If that patient's heart failure doesn't meet these qualifications, that is, persistent, important MR despite exposure to optimal medical therapy, a defining difference between COAP and MITRA-FR, the results you hope to have may not be those that we are trumpeting when we look at the primary results of COAP. Now, that means that if you were an operator and you intend to do mitral valve interventions by whichever technology is currently present or will be present in the future, we have to be facile with GDMT. That is, your team has to be facile with GDMT. So what constitutes GDMT? This has been well articulated in the heart failure guidelines through several iterations, and I've represented this for you here. There's no need to go through this in a very structured way. simply to say there are a number of highly regarded evidence-based therapies that work well. We've taken one extra step to make this easier, and we've actually developed an app. This is the Treat HF app. It's available in the App Store, in Google Play. You enter your patient's parameters. It will then identify for you the indications appropriate for that patient and give you references for why those indications are appropriate. So we've tried to make this palpable, accessible, and implementable. But recognize that GDMT today is a moving target. This is why. There is an incredible amount of excitement and enthusiasm in the heart failure field that we've added yet another important pillar to GDMT, and that's the sodium glucose cotransporter 2 inhibitors. This is a schematic of what we think those drugs do. We understand that there may be a change in myocardial energetics. We understand that there are loading parameters that are varied, particularly afterload. There's a drop in blood pressure. We know they have a mild diuretic effect, and we know they have important renal effects. But what we also know is this really is an important timestamp in our drug discovery process. We all recognize that for years, we never had an anti-diabetic therapy deemed to be safe in the cardiovascular space. So much so that the FDA mandated that any new anti-diabetic therapy must include a safety analysis for cardiovascular events. In pursuit of the safety analysis, these remarkable data emerge in the EMPA-REG outcome study, that's with empagliflozin. As you see here, an inexplicable but decided advantage on the necessity for a first hospitalization for heart failure. That was no longer deemed a statistical fluke once we saw that 3 different programs using canagliflozin, dapagliflozin, and empagliflozin had completely synthetic or synergistic data points, demonstrating all data points going in the same way. This was for those with atherosclerotic disease already established, those with multiple risk factors, a decided advantage, as you see here, that favors treatment. What could possibly be going on? Again, I won't belabor this other than to say, I want you to see what happens to the fibroblasts, the purple cells, here in panel A, in a setting of hyperglycemia. There's an overload through the sodium glucose transporter receptor of the sodium potassium ATP bump, a very high energy process that yields the region of hypoxemia that then generates stress. Those purple fibroblasts then undergo a biotransformation, and instead of making erythropoietin, which is their usual functionality, they elicit a pro-inflammatory signal that is a pro-growth signal. And it is the introduction of the SGLT2 inhibitor in panel C that interrupts that pro-growth signal and returns those fibroblasts back to making erythropoietin. And one of the consistent observations in all these trials has been an increase in hemoglobin independent of volume contraction. So this is at least a prevailing concept in the setting of diabetes. But then everything changed again. We now have what we all consider to be landmark data from the DAPA-HF study using dapagliflozin. What makes this so profound is this observation. Patients were enrolled with heart failure and independent of whether or not they had diabetes. So understand the frame shift I've just taken you through. The original data points were in diabetic patients with risk factors where there was this inexplicable signal of reduction in the incidence. That was replicated through 2 other study profiles with a plausible mechanism for why it might have worked. Now the transition goes to those with heart failure, with or without diabetes, an important study to have done because the benefit seen was independent of glucose lowering, so it suggested that some of the process was going forward. And here we see that in those with and without diabetes, the addition of dapagliflozin was impactful, a reduction in a combined endpoint of death or cardiovascular events. We really believe that this has become an inflection point, and this is something that necessarily must be considered in future iterations of GDMT. It's really easy. It's a 10 milligram dose of dapagliflozin. It's given once a day. There is no titration. There were no meaningful episodes of hypoglycemia or ketoacidosis, negligible incidence of distal limb amputation, which had been an earlier concern in one study. The number needed to treat was only 21 to prevent one important event, and we have data for the first time in patients greater than the age of 75 of efficacy. This is a remarkable data set and really is an important tool that we now have that we did not have before. Dr. Brunwald, just 2 months ago, indicated that this is a war against heart failure that we may finally be winning, that is this intersection of diabetes and heart failure over a 20-year history, witnessing the development of these drugs emerging from the diabetes platform to the non-diabetic platform, from prevention to therapy. And so he has suggested, and I endorse this, that we now have a 5-component foundational platform for therapy that reduces mortality in heart failure with reduced ejection fraction. That means that in your team management schemes where you're looking at patients with heart failure who are candidates for valve interventions, there are 5 platforms now that must be considered very carefully, I will say this, as obligatory if you are to maximize your patients' outcomes. But it's a challenging target. These data are very sobering. They demonstrate that when we evaluate real-world use of evidence-based therapies, we find that only 1% of patients with a clear indication for evidence-based therapy for reduced DF heart failure are on a representative drug from each of the major classes shown to be efficacious at a dose that has been shown to make a difference in the natural history. Let me emphasize that again, only 1%. Only 25% are on at least some therapy from each of the drug classes. Huge opportunities for improvement there. You might say, this is simply because patients show up with marginal blood pressures, and many people are very fearful of hypotension in the setting of heart failure. But even when you separate out patients with a blood pressure greater than 110, you see the same reluctance, the same hesitancy to use evidence-based therapies, with only 2% receiving the RNA compound despite having systolic blood pressures greater than 100. This is the most sobering graphic because you can argue that that was an ice pick view. What about longitudinal? People are aware that they're being assessed, the quality metrics are being evaluated. You would anticipate that the Hawthorne effect alone would yield change. But if you look at the dose at baseline into 12 months, the red slice of the pie tells the story. That's where there was either no change in the dose or the drug was never initiated, showing you profound opportunities for improvement, but also a very low threshold of adherence. Now, how can you decide what dose is right? When do you know that GDMT is adequate? You heard an earlier conversation from Dr. Nishimura about the importance of biomarkers. These recently published data really highlight what happens if you take the NT-proBNP greater than 1,000, such as it was in COAB, and treat those patients to a threshold less than 1,000. This is what happens. If you look in the red lines, you see those patients who either had a low NT-proBNP and remained low, or had a high NT-proBNP, and with therapy, it was reduced. The outcomes are quite good and akin to having had a low threshold to begin with. And moreover, if you look at left ventricular ejection fraction, left ventricular end diastolic volume, left ventricular end systolic volume index, left atrial volume index, and parameters of diastolic function, everything improves. Now, this is an important statement because what I'm telling you is that as we see the biomarker fall, we can identify important evidence of effective left ventricular reverse remodeling. These are the kinds of changes that take the symptomatic patient to one that is less symptomatic and has better outcomes. So the final thought to share with you is this. If we did the right thing for the right patient all the time, with all of the known to be effective evidence-based therapies, in this model that Dr. Fonero and I have just completed and that is pending publication, you discover something remarkable. The number needed to treat to save one cardiovascular event is 3.9. This is for reduced DF heart failure. This is a condition where at the beginning of my career, the one-year mortality was 35, 40%. And now we can get the number needed to treat to 3.9 and an absolute reduction in mortality of over 25%. This is very meaningful. So be aware of these challenges. Challenge number one, the complexity of treating heart failure has increased. Challenge number two, we have 8 evidence-based therapies, 4 devices, an array of disease management schemes. This is big boy stuff now. This is professional stuff. You can't just be a pedestrian and treat heart failure. Big girl as well. You have to really have the expertise. There are major challenges in drug titration. Adherence requires a team-based approach. I think that personalized medicine, machine learning may help us do a better job. Understand this, and we have to keep this in mind. All of the therapies we're talking about today, drugs and devices, costs money, and patients are held accountable for more costs than we realize, and this is another important conversation to have. So this is what's required to be successful in the valvular heart disease program, a multifaceted team, focused on medical therapy, focused on the patient's needs, focused on the procedures. And I'll leave you with this thought. We've always known what to do, but knowing is not enough. We really must apply, and that's uniquely important when we're talking about GDMT. Thanks very much.